it's a big treat for me to share some information about DC with you and also be the reactor or responder to Paul's work. Paul and I met years ago. Neither one of us remembered when, which tells you that if you've been around long enough, you know folks who do good work, and I certainly have relied on Paul's research over the years and think his reports are tremendously helpful. And his report, this current one, and I encourage all of you to read it if you haven't, on the DC area is very good. I'm advertising Paul's report now for you, since I'm on a roll on that. So I'll start by saying,
website.
I'm sorry?
Which is on the Foundation's
website. I'll start by saying thank you to Dr. Koo. He's on my board, and I appreciate him being an active board member and having me here today. And my board chair, Diane Lewis, is also here. So I just want to acknowledge both of their work. We are a quasi-government agency, essentially a private-public partnership, so we're not a traditional government agency. And we have a working board, so that means if you are selected to be a board member, you're expected to work essentially pro bono. And in fact, before I was hired, January of 2013, the board did all of their own work. They had no staff, so they had to roll up the sleeves and jumpstart the implementation. And I have to say, I really appreciate Paul's paper. I'll read you a quote. The DC exchange performed better than many expected, which is absolutely right on. We were the last state to start the IT build. The city didn't sign its IT contract until January of 2013. I was the first employee that the executive board hired. And I came in January of 2013. And I would say the 9 months leading up to October 1, 2013, is like a high-risk pregnancy where every day is very challenging, and some days are more miserable than other days. But anyway, the good news for us was we did roll up our sleeves, and the entire community, all of the stakeholders engaged and helped us get it done. So on October 1, 2013, we opened for business, and we opened both on the individual side and the small group side, and we were one of 4 states that opened on time and stayed opened, and it was great to be acknowledged by Bloomberg News that we were one of 4 states. In fact, because we had much of the core functionality, OPM designated us as a source of coverage for all of Congress, including district offices. So members of Congress who receive job-based coverage, as well as designated staff, all come through us, no matter where they are. And that was quite an accomplishment. And also in December of 2013, the President of the United States enrolled through us. And then last year, we renewed his coverage, so he stayed enrolled. Thank you, Mr. President, for paying your premiums on time. I'll share some data with you on where the enrollment numbers are. But to this day, I'm convinced that we have so many people choosing bronze coverage because that's what the President enrolled in. And we think lots of people do what the President does. So I'm still very upset that he didn't choose platinum coverage. But so just a few data points to share with you. Since we opened for business, we've had over 186,000 people come through DC HealthLink, and that includes group coverage, small business coverage. It includes our congressional customers, and it also includes individuals who signed up for qualified health plans through the individual marketplace, as well as folks we've determined eligible for Medicaid. We have no wrong door, so anyone looking for coverage, whether it's Medicaid, premium reductions with APTC, or full pay, come through us. A little bit about the demographics for us. We probably have the youngest risk pool in the nation. The largest enrollment by age, 26 to 34-year-olds make up 41% of our individual enrollment, and 75% of enrollees are 44 and younger. That's on the individual side, not the group side. So it does not include the teenagers who work on the Hill. This is just the individual side, and we work very hard to get younger folks enrolled. We know based on data analysis that Dr. Koo did for us before we opened, that a significant portion of our uninsured population was 40 and under. So many of our outreach efforts focused on the younger members of our community. In terms of what folks are selecting, 29% are in bronze coverage, 26% in silver, 23% in gold, and 18% in platinum. 4% in catastrophic plans. Now that's the number I worry most about, because many of our bronze plans are less expensive than catastrophic plans. So in the near future, we'll be looking at why it is that customers are still choosing catastrophic plans when they can get a better deal financially, lower premiums per month with a bronze plan. On the shop side, 48% of small business enrollment is in platinum and 32% in gold, 16% in silver, and 5% in bronze. And this goes directly to something Paul said very well in his paper. In this area, employers like to provide very rich benefits. Now, all of you know, because of the Essential Health Benefits benchmark, essentially all the benefits themselves are the same. It's just the cost sharing that varies. And most of our customers on the group side choose to be covered in platinum. Now, in addition to the demographic information that Paul referenced earlier, law firms, consulting firms being in DC, we have a very significant nonprofit employer community. And the way they compete is through benefits, not direct wages or salary. It's benefits. So many of the nonprofits offer 100% employer paid for health coverage, and they're choosing the platinum or the gold level, because that's how they can compete for labor. The most popular plan by volume is a point of service plan. And looking at the individual enrollment, this does not include group. On the individual side, 49% are in HMOs, which actually surprised me. I expected a much lower enrollment in HMOs. 29% are in PPOs, and 22% have a point of service plan. Now, when I say HMOs in this area, and Paul covered this in his piece, HMOs have very broad networks. More narrow networks are, those products have not done well in this area, and even the products that have local networks tend to cover providers all over Virginia, Maryland, parts of Pennsylvania, Delaware. So even the local network products are pretty broad, much broader than one would expect. In 2016, we have 136 different qualified health plan options for small businesses and their employees. And on the individual side, we have 26 different options. So Paul referenced this as gazillion options. Actually, we're doing much better, because in the first year when we were open for business, we had 267 different products for small businesses and 34 different products for individuals. And initially, when we were preparing to open our doors, the biggest concern we heard was, will there be enough choice? After after we opened our doors, the biggest concern from brokers and from advocates and from small business owners was too many choices. Even with search engine online to help you look for the exact product you want, too many choices. And the carriers have learned that essentially if no one is signing up for a product they're offering the first year, don't offer it the second year because consumers are just not interested. So they themselves have eliminated products that are not doing well in this particular market. I'll make two other points. The next point I want to make is relates to some of the market highlights section in Paul's paper. Paul is absolutely right. When we started, we did not have a competitive insurance market. And in fact, most states, there's probably 1 or 2 states that have a competitive insurance market, health insurance market. So when we started, we wanted to leverage the Affordable Care Act to help create more market-based competition. And the way we did that was to create, to make us, DC HealthLink, the sole distribution channel. So essentially, all individual health insurance and all small group insurance, health insurance, is sold through us. So when there's only one distribution channel, what that means is full transparency. In one place, consumers can go and get all prices, all benefits, all in one place. And I have to say that in the first year after the law was passed, when health insurance companies filed their premium rates, it was incredible to watch competition for business. One health insurance company lowered their proposed rates twice because they were afraid they priced themselves too high. Another company lowered their rates and filed additional products. And a third company lowered the proposed rates, essentially. So it was interesting to watch that the insurance companies realized that for the first time, it's full transparency where consumers are in the driver's seat and can look at all prices and compare benefits. So that has helped create more competitively priced products for our customers. The other goal we wanted to accomplish by creating the single distribution channel is that we wanted to eliminate barriers to entry. Some of you know that it's really expensive for insurance companies to come into a new market. They have to establish their provider networks, their broker relationships, distribution channels, internal company mechanisms. It's super expensive. And it's especially expensive when they know the current players in the market could just underprice them. So huge barriers to entry. And we wanted to make it easier for insurers to come and do business here. And so by creating the single distribution channel, that makes it possible for carriers to come in if they're interested in playing in the market and seeing if they can succeed. We also, in the first year, made a policy decision not to allow benefit substitution in the essential health benefits benchmark. And what that means is it eliminates risk for carriers that in benefit design, they may attract a sicker population than the competition. And so by eliminating that risk, that also makes it easier for carriers to come in should they want to. And remember, DC is one of the smallest population states. And if you live in DC, you appreciate reference to state, right? No one lives in DC? Do you vote? There you go. So we've eliminated many barriers to entry, and we believe that eventually could create an opportunity for new carriers to come in. But it is a small population state, so the margins have to be significant enough for a carrier to make a small investment. Initially, our initiative of the single distribution channel was not supported by everyone. There was angst among the business community especially. And I can tell you, after the first year being in business, some of the loudest critics and people who expressed concern supported our effort. They saw their premiums go down. They saw real competition for their business. So all three largest chambers of commerce support our approach. The DC Chamber, the Restaurant Association, Metropolitan Washington, and the Hispanic Chamber of Commerce. And the insurance companies are seeing our approach as a way that they can actually compete more effectively on par, same level playing field that they would tell you they didn't have before. It will be interesting to see in 5 years whether or not market share for the largest company has changed and whether or not the other carriers have made a significant dent and increased their market share. But we won't know that for another couple of years. The last point I want to make is something that Paul talked about, the low uninsured rate in this area, especially in the district. So when the ACA was enacted, we knew it created huge opportunities, but we also knew that it would be a challenge for us. So no low-hanging fruit. The district has invested a significant amount of resources over the years into coverage expansion and care expansion initiatives. Paul talked about one of them, the alliance that we have here that covers a population of our community that doesn't qualify for Medicaid, for example. So we knew that starting with a low uninsured rate, we'd have to be very creative at finding the last remaining uninsured people. The other challenge we faced is that the DC market, media market, is one of the most expensive markets in the nation. And in 2013, we had local elections in Virginia, so ad space was 10 times more expensive. Also in 2013, if you recall, healthcare.gov had technical issues, and there was a lot of confusion. There was a lot of confusion whether or not we were part of healthcare.gov, could people still enroll, and the federal government got a lot of earned press. They probably didn't want it, but they got it, and so people here were reading the terrible stories, and that led to a lot of confusion for our residents believing that we didn't have a system that worked. So we had to overcome that. A small advertising budget, tiny compared to others, and a lot of wrong information that we had to counter. And back then, if you recall, there were also discussions about death panels and just all sorts of stuff that wasn't true about the Affordable Care Act. So that was an additional challenge. Now the good news for us is we figured out how to be creative, and we were creative. We did all sorts of things to reach the uninsured. We went to bars, nightclubs, not me personally, but people on my team did. We had 24-hour ongoing enrollment rally at different parts of the city. So we started at some of the community health centers, and then at one point in time we were at Ben's Chili Bowl, and then we were at the diner at 5 a.m. You can sign up for health insurance at the diner. So we did lots of creative things. If you ordered pizza on Super Bowl Sunday last year, you got a reminder of the deadlines. So we did lots of creative things to get folks enrolled. And the last census report shows that our uninsured rate dropped by 20%. So we're very, very proud of that. But it doesn't mean that we stop. We want to get to every single person who is without coverage. And that's what we continue to focus on. The one concern I have, and this is where some of you may be helpful to not only us, but other states, is that federal grant dollars are no longer available after this year for enrollment, for new enrollment. So the groups on the ground we work with who rely on grant support to do in-person enrollment to help customers, consumers, to get enrolled, we will no longer be able to fund them at the levels we fund through the federal grant. So I'd love any creative thinking that you have, any advice for me about how to tap into other federal grant sources or other grant sources in order to continue funding our organizations on the ground. The lesson that we've learned about our population in the district is that it's very diverse, and some people will never go online to shop for health insurance, ever, ever. Other people don't ever want to talk to a live human being. They just want to get online, take their 10, 15 minutes, and some have done it in 15 minutes, and just get it done. So for folks who want to talk to someone, and not just someone, but they want to talk to their neighbor or a trusted voice in the community, the only way we can reach those folks and have reached those folks is by having in-person assisters, members of the community, talk to folks and get them enrolled. So that's my concern. If we lose a resource there, it's going to be even more challenging for us. And all state-based exchanges are in the same boat on that. I'll finish by saying, by covering one more issue, and that is the Cadillac tax, which Paul also talks about. Now, full disclosure, my board doesn't have a formal position on this. We haven't discussed it. One of my board members has written to Congress saying this is the best thing since sliced bread. And I personally think it needs to be repealed. So there is no official position from my board. But I can tell you this, one of the lessons I learned when I was insurance commissioner in Maine, and I actually reviewed rates and held rate hearings, is that premium rates are based on two critical factors. One is, who are you covering? If you cover older, sicker people, it doesn't matter how bare bones your package is, your employees are going to use services. Your rates are going to be higher than an employer with younger, healthier workforce. The other factor that matters is the cost of care. And if you are in a very high cost area, like Miami, New York City, DC is a high cost area, per heart attack, you're going to be paying more than you would if you were in a lower cost medical services area. So the Cadillac tax doesn't make any sense to me because you can have the exact same benefits, exact same cost sharing, and if you have one employer with sick or older workers in a high expense area and another employer with younger workforce in a low cost area, the same benefits package is going to be very different in terms of premiums, and one employer is going to be paying the tax, the Cadillac tax, and another employer is not going to be paying that tax. So this is one area where I probably have disagreement with Paul and probably some of my board members. I haven't had the discussion with them yet about this, but it is something to look for as the ACA continues to be fully implemented. And with that, I will close and happy to take any questions.